preventing antimicrobial resistance patterns, how we can leverage evidence from sustainable impact in primary healthcare. So our learning objectives today should be to explain the two distinct mechanisms by which IPC prevents antimicrobial resistance, distinguish activity reporting from indicator measurements, classify IPC indicators. We're going to look at them as structural indicators, process indicators, and outcome indicators, as well as AMR impact measures. We're going to define, calculate, and interpret the core IPC and AMR indicators, including their denominators, assemble a minimum viable indicator set for our primary care or district facility, and build a loop that converts an indicator into a change in clinical practice. So let's get straight into it. Why IPC is an AMR intervention? What we see is for the global and regional burden, 4.95 million deaths associated with bacterial antimicrobial resistance globally, and 1.27 is attributed to resistance. And why are we getting this antimicrobial resistance happening to begin with? You'll see that 15 in 100 hospitalized patients in the low and middle income countries acquire at least one healthcare associated infection. 24 out of 100,000 AMR attributable deaths in sub-Saharan Africa alone, and up to 1 in 4 patients have healthcare associated sepsis die from it. So let me collapse this a bit. Apologies. Yes. So let's look at how IPC prevents AMR through two distinct mechanisms. One, we can reduce selection, and two, we can reduce transmission. If we have fewer infections, that means fewer antibiotic courses. Fewer courses means less selection pressures on each patient's commensal flora. And if the patient's flora is not being exposed to antibiotics, then what happens is there's going to be less resistance to begin with. Another way is to reduce transmission. Where resistance has already emerged, IPC interrupts the movement of the resistance amongst patients, between patients, and also between patients and staff as well. So what the evidence supports and what it does not. We've seen how hand hygiene programs are associated with reduced healthcare-associated infections, with reduced in resistant organ transmission. We've seen how if we come up with good surgical bundles, and we're going to look at what that entails later, it reduces surgical site infection rates. We are going to see, how water, sanitation, and waste, if we had good prerequisite, if we have good handling, if we come up with good surveillance systems, that we're able to come up with behavioral interventions that actually slow down antimicrobial resistance spread. Contact precautions and cohorting, if you're able to identify patients who are multi-drug resistant organisms who have it, if we're able to isolate them quickly, then we were able to break that transmission. What is weaker? Facility level casual attribution of resistance, reduction to any single IPC component. So it's not a single IPC component, it's the entirety of it. So a framework for choosing indicators. So most IPC programs report what they did, but very few report what changed. So what we usually see is number of staff trained, IPC committee formed, number of sensitization session held, cartons of gloves and soaps, procured, World Health hand hygiene commemorated. But what we don't get to see a lot. What we don't get to see a lot is what actually predicts AMR. So we don't get to see hand hygiene compliance, especially in areas where you have ACL regions like here. You're not going to see hand hygiene compliance being followed through. If you ask someone what percentages are expected in the WHO, what indicators that is, most people will not be able to tell you that. SSI rates per 100 procedures, what is the 100 liters per 1,000 patient days? What does WHO expect us to have? The cultures taken before antibiotics and resistant isolates per 1,000 patient days. So those are the measurements that we need to be seeing that marry between IPC and AMR. So there are 4 levels of measurements, as I mentioned during the introduction. I hope I'm not too fast. We're going to look at structural indicators, process indicators, outcome indicators, and impact. So what does structural indicators entail? Do we have what is needed? Do we have an IPC for per person? Do we have the water? Do we have the hand rubs at point of care? Do we have the capacity? Process is, are we doing it correctly? Outcome would be, did the infections fail? And impact would be, did use and resistance fall? So let us look at 5 rules of a usable indicator before we go into the different types of indicators. You need an explicit denominator. So we're thinking a number like 100 or 1,000. So per 100 procedures, per 1,000 patient days, per 100 opportunities. You never need a raw number because it's going to be hard for you to be able to measure it upward. You need a case definition anyone can apply. So 2 nurses auditing the same award must be able to produce the same number. So confusion must be very little. You need a data source that already exists so that you don't have to worry about surveillance. So we're thinking theater registers for SSI rates, laboratory registers for cultures, pharmacy vouchers, and sterilization logs. You also need a named owner and a fixed cycle. So we need one accountable person who will be able to give us this level of data and an action threshold agreed in advance. So what would trigger a response? So I'll give you a worked example, turning an activity into an indicator. So we say we trained 60 staff on hand hygiene this quarter and produced 40 liters of hand rub. So what would be the indicator? The indicator here would be hand hygiene compliance, which essentially is the number of correct hand hygiene actions performed over the total number of opportunities observed, meaning the total number of times maybe they touch the patient times 100. So this would be, let's say, maybe 30% or 40%. And then from now, that indicator, be able to deal with the consequence. Did this number fall? Did it increase? And from this indicator, you'll be able to say, yes, maybe our hand hygiene compliance is coming down, meaning that the risk of us having antimicrobial resistance in our patients would be high. So let's go through the structural indicators for IPC. So structural is, we're lucky the WHO has given us a very detailed infection prevention control assessment framework known as IPCAF. It scores a facility between 0 to 800 to be able to tell us whether this facility is able to uptake these IPC indicators. What is the risk of such a facility having antimicrobial resistance? And it gives us a general view of where a facility stands. What is needed is an IPC program, multimodal strategies, monitoring and audit and feedback, evidence-based guidelines. This is all IPC elements. Education and training. How do you surveil healthcare-associated infections? Do you have an environment and the capacity to be able to do staffing? And does the hospital have bed capacity? Is the spacing between the beds correct? So there are elements in which a facility would be measured against to say, okay, this facility has a specific number of, there's a percentage for each, usually for each component. So maybe we'll say IPC program is present. There's a committee that's active. So that's at 20%. So at the end of it, there's a banding. So let's say facility A scores between 0 to 200, meaning it has inadequacy to be able to carry out just basic IPC functions. So that puts that facility at a higher risk of HAI spread, of SSIs, of cross-contamination. So we are hoping that we target 200 to 400 basic and above. Let's look at what to track in the primary care facility. So with the smaller hospitals and smaller centers, IPCAF might not be ideal because let's say there isn't a committee that's available because maybe all the members that are required are not available. So smaller versions of IPCAF exist, something known as a wash fit. So let's look at hand hygiene compliance. Forgive me, I'm in public. Bear with me. Sorry. So let's look at hand hygiene compliance, process one. What does that actually entail? So that would be the WHO 5 moments. Did you wash your hands before touching a patient? Before a clean or an aseptic procedure? After body fluid exposure risk? And I'll tell you this, in ASL regions, because there's a myth that HIV is not spread quickly, or there's a myth that we are a low prevalence region. I have seen a lot of staff who end up touching patients' blood with their own hands, and they don't practice hand hygiene as actively as required. So we're seeing this on ground. After touching a patient's surroundings, or after touching the patient themselves. So 3 rules that decide whether it is useful. Remember, we mentioned denominators. We need good denominators. The denominator is opportunity, not staff. Okay. So you'll be able to say at the level of the cleaners, we have 80% hand hygiene. At the level of the clinicians, we have 30% hand hygiene. And maybe at the level of the consultancy, we have 15% hand hygiene. So from there, you're able to plan on how to come up with measurements, come up with policies, or come up with ways on reducing or increasing the compliance and reducing future antimicrobial resistance. Okay. So process 2 is alcohol-based hand rubbed consumption. So what does that actually entail? So that entails consumption of alcohol-based hand rub issued to the unit, divided by patient days times 100. I know there's a lot of formulas here, but bear with me. This is how we are able to come up with measurable indicators. When we look at IPC, when we look at AMR, measurable indicators is what matters. If we're able to see an upscale, then we're able to prevent something from happening. So for this case, for example, if we look at the worked example, we'll see what issued with maybe the 18 liters has been issued to maternity, and the bed capacity is 42. So if we do the math, we get 938 patient days, for example, in this case. So if we divide that by the liters that we were given, the alcohol-based hand rub consumption would be 19.2. And the WHO expects us to have above 20 liters per 1,000 patients, okay? So the third one is very, very, very important as well. Surgical antibiotic prophylactic quality. So this is something that is we have seen as part of a working group across Eastern and Central Africa, that our clinicians tend to over give antibiotics, especially in cases that are maternity. If there's a patient who is coming with a CS, you'll find a patient has been put on ceftriaxone and flagyl for now, despite the case being a clean case, despite there being no indication for it. So we need to be very wary of how we misuse our antibiotics. So when we look at process 3, we look at the timing. Assume this is a clean case, then there's no indication for long-term use of antibiotics. Cefazolin is usually given. It's administered within 60 minutes of a cut. So the timing, so percentage administered within 60 minutes of an incision. Duration, percentage stopped within 24 hours of surgery. And the agent choice. Are we choosing access medications? Are we running to aware? Are we even starting with reserve? So there is a method to prevent antimicrobial resistance at the basis. So percentage receiving the guidance recommended agent. So we want broad spectrum as we do our cultures. So the process 4, the rest of the process set. This is based on the IPC elements that I spoke about. Environmental cleaning, for example, percentage of scheduled high-touch cleaning rounds completed. Injection and sharp safety, percentage observed injections meeting safe practice. I'm sure some of us in the clinical field have seen an injection left by the bedside after perhaps a procedure. That in itself is a risk, not only to IPC, not only to transmitting other various infections like hepatitis B as well. So there are elements, there are indicators for each process. And if we're able to target and have a map or a chart where we're able to see how we're doing, the end result will be different. Isolation and cohorting is very important as well. So the percentage of eligible patients placed under appropriate precautions. We spoke about multiple drug resistant organism patients who are exposed, and sometimes their relatives come and visit them. There hasn't been a proper isolation. There hasn't been a proper system that has been put in place for such a patient. So we need to make sure that our indicator shows that there is a reduction in the number of patients. There's an increase, sorry, the number of patients who are being isolated. So let's look at our outcome indicators. So let's look at surgical site infection rate, which is the surgical site infections identified. We divide that by the procedures of that type performed times 100. So as we spoke about earlier, we see cesarean ends up being the first one. And this is because of just the high volume. So the denominator is stable month to month. And the ascertainment problem is sometimes you think a failing SSI rate may mean infections fail. It could be that you're not identifying it the correct way. Most cases in our settings are lost after discharge. Patients travel long distances, present elsewhere, or they abscond. We have a lot of abscondees in ASO regions. So you will sit down and you look at your SSI rates, and then you say, oh, my facility is improving. But in reality, you're missing patients or they're developing SSI long after they've placed. So there needs to be a follow-up procedure as well. So outcome 2 is device-associated infections and MDRO acquisition. So device-associated infections are events divided by 1,000 device delays, only where devices are genuinely in use and device days can be counted. Okay, so this could be if your patients are on ventilation systems, they're on central line, patients who are on dialysis. If what we need to be able to say is, has there been a device-associated infection? For example, maybe they have inserted a device day 1. A patient begins to have high fevers day 2 or day 3 after the device has already been inserted. That is an event. So that's how we'll be able to calculate our infections. So we'll be able to say perhaps we are not sterile enough, or we're not following septic techniques while putting in the device. Okay. MDRO acquisition rate, I have spoken about this earlier. We'll be able to also need to look at colonization versus infection. Decide and document which you are counting. Mixing the two across months may take trends uninterruptible. I'll give you an example. We had a case where a patient had stool, and this is something we presented just about recently, where they came in and they have abdominal pain and they have stool for loose stool for 3 days. But when we look at when we did the culture of the stool, we found that the patient was resistant to everything. Initially, we believed that the patient was suffering from MDRO, multiple drug resistant organisms. But it turns out that what we were looking at was not an infection, but a colonization, because the patient had been in another facility and he was already on antibiotics for 2 to 3 days. So you need to be able to ascertain the difference between the two so that you don't end up having high indicators, high measurables, and say, oh, I'm getting, my hospital is beginning to have a high rate of infections. The problem might be a colonization issue. Okay, let's see how we can bridge indicators that connect IPC to AMR direct. Without this, you are reporting infection control alone, not resistance prevention. Remember, while we began, we were talking about how we can ascertain IPC indicators that will prevent AMR. Now we're looking at indicators that directly connect the two. For example, blood culture utilization. Lower utilization means resistance is invisible, but not absent. Cultures before first dose. So we want to have a high number of patients who are being cultured before the first dose. I think a colleague of mine was working on a study to see if there's been an increase in culture uptake after the antimicrobial stewardship committee came forward and trained the medical staff to adhere to ensure that more patients have their cultures before we give antibiotics. Contamination rate, percentage of contamination on all sets. So this is an IPC failure with a direct AMR consequence. If our contamination rate is high, that means our hand hygiene is poor. That would also indicate a direct AMR consequence, because assuming you have a patient who has MDRO, we do not practice hand hygiene compliance. That patient ends up transferring or cross-contaminating that MDRO to other patients, to the staff as well. Antibiotic consumption, the exposure that IPC is meant to reduce. Remember, we said IPC, if we do a good IPC guidelines, if we follow through, then the need for antibiotics will be reduced. Then the exposure of patients' commensal flora to such antibiotics will also be reduced, and AMR will be reduced. Aware access share, percentage of consumptions in access groups. We want more patients to be on broad spectrum antibiotics. This is after they have been cultured for the first dose. The higher the access, greater than 70% at least, it indicates that we're moving away from stronger drugs in the watch category and in the reserve category. You'll notice that ceftriaxone has become a medication that a lot of hospitals tend to fall back on, especially private sectors, while we could be starting with access medications such as ampicillin, amoxicillin, and whatnot. Resistance proportions. Sorry, I think I'm tracking. Okay, resistance proportions. Percentage of resistance of isolation tested. Interpretable only alongside the utilization rate above. Okay. I hope I'm not moving too fast. So let's look at the bridge. Diagnostic capacity is an AMR indicator. A facility cannot practice stewardship. It cannot measure. And it cannot measure what it never cultures. So raising blood culture volume as itself is an AMR intervention. It is what makes every downstream resistance number mean something. Okay. Bridge 2 would be antibiotic consumptions and the aware mix. So consumptions is usually identified through the defined daily dose issued, divided by patient days times 1,000. So what does defined daily dose give you? It's a standardized unit created by WHO to be able to help us to ascertain the amount of drugs that's being used per patient, for example. A standardized unit that allows comparison across agents, wards, facilities, and years. Computable from pharmacy issue data alone. No prescription audit will be able to give you this. Aware classification. So what are we talking when we speak of aware classification? What are we talking about? I know I forgot to touch on this, so let me just give you a small introduction on what it is. So access is the first line agents with low resistance potentials. Watch is usually the higher resistant potentials, restricted indications. Reserve is our last resort agents. I'll give you an example of a patient who has pneumonia. When they come in, the first antibiotic you think of giving them is probably piperacillin, tazobactam, ampicillin, amoxicillin. These medications have low resistance potentials. This is because of the way they are designed. Assume this patient we started them on ceftriaxone, cefuroxime, cephalosporins, or any other category that is usually within the watch. They have a higher resistance potential. When the resistance happens, and this patient will not be able to heal quickly because we started them on a watch category. If we started at access the right way, and if access fails, then we move to watch. Or we can even switch to a different access. But what happens in our settings is many patients will be going to different institutions and they're getting the watch drugs first. So enough times means that the patient's gut is going to start developing carbapenem's resistance to beta-lactams, and eventually the watch medications now are not suitable for our whole community. Like here in our region, a lot of patients are resistant to watch agents. So we are switching to alternative access drugs before we run to our reserves. So bridge 3, reading resistance data honestly. We need to report the denominator. A lot of times you'll see in a report 38% of isolates were resistant, but it means nothing if we don't know what the denominator was. What is it being compared against? Separate colonization from infection. We've spoken about this. Use accumulative antibiogram. Compiled at least annually. First isolates per patient per period, with a minimum isolate count stated for each patient. Align with GLASS. So GLASS is the Global AMR and News Surveillance. It's a kit that the WHO had created to be able to help us to follow up on antimicrobial resistance patterns, to be able to track how antibiotics are used and antibiotic consumption. So we have an existing framework where we're able to refer to. State what you cannot say. Facility data is observational and confounded by seasonality, case mix, staffing, and outbreak cycles. So let's look at how an IPC indicator becomes an AMR outcome. Let's start with hand hygiene compliance. I've spoken about hand hygiene compliance a lot today. So let's say we've increased our hand hygiene compliance. The next thing that's going to happen is transmission of infections and healthcare associated infections will go down. And if it goes down, then empirical antibiotic exposure will go down. And when that goes down, then the resistance will go down. So it's a very clear picture how important IPC indicators reflect with an AMR outcome. One does not move without the other. Each arrow is a measurable step. If compliance rises, but HAI, healthcare-associated infections, does not fall, ask yourself, which link broke? Was ascertainment poor? Was the gain confined to one cadre? Was the drive as sterilization failure? A broken link is a diagnostic information, not a program failure. The second, quieter arm. IPC also blocks the spread of organisms, as we've seen this, that are already resistant. So if we are washing our hands, we're going to prevent the spread of multi-drug resistant organisms from moving forth. So IPC acts as a block. Stewardship cannot do this at all. It is why IPC belongs in every national action plan on AMR as a primary pillar, not a support. This is just a minimum viable indicator set for our PHC facility. So we see we have hand hygiene compliance, hand rub consumption, water availability, surgical site infection rate, prophylaxis duration, blood culture utilization, aware access share, and IPCAF, which we spoke on earlier, where the data already lives. Luckily, for IPC indicators with AMR interventions, most of these things, we already have them in our systems. So all we have to do is just go back and find them. So for theater register, you'll be looking for surgical site infection rates. For pharmacy issue vouchers, you'll be looking for AWARE. Sterilization log, you'll be looking for decontamination rates. For laboratory register, we're looking for cultures and isolates, susceptibility, and resistance patterns. For maternity and ward registers, we're looking for everything. It's practically everything. And a facility utility log tells us how often what is available. I'll tell you, as somebody who works in a ASL region, water availability is something that is it comes and goes. I think right now there has been a good job that's been done by the county to ensure that the water is available at the hospital. But sometimes what happens is if there's an unavailability of water, hand hygiene cannot be practiced. And if hand hygiene cannot be practiced, then we're getting these MBROs that we see. So this is what a monthly run chart looks like. See, we have 12 points, not one. The eye needs the trend. A bar of the current month tells the world nothing. So we will be able to say we are improving with our hand hygiene compliances. We are improving with our hand rubs liters per 1,000 patient days. Seeing an upward trend or a lower trend helps us make policies. It helps us make changes. From measurement to action. Let's look at the feedback loop. So we collect one page monthly, the same method every time. We display ward level run chart on the wall, not in a drawer. We discuss 10 minutes inside a meeting that already happens. We act one small test of change per cycle owned by a named person. Remember at the beginning we said for as WHO had required IPC committee, there needs to be an IPC committee. If there's an absence of an IPC committee for smaller facilities, there needs to be an IPC focal person. So this focal person will be the person who will be able to collect this data and escalate quarterly to management, annually to the county AMR committee. 8 ways indicator programs fail. So you have numerators without denominators. You have resistance on tiny denominators. You will have no feedback loop. Changing the definition mid-year. So you want to change maybe your aware access definition all of a sudden. You want to change what you consider to be a failure hand hygiene compliance rate in June. When you had decided in January, perhaps you want a 90 to 100% hand hygiene compliance. So those are the reasons why programs tend to fail. Indicator inflations, 30 indicators means none are acted on. So you don't want to have many indicators. You want to have main indicators, easily measurable, easily be tracked in files, and easy to be acted upon. Punitive use of data, tie an indicator to blame, and it is reported beautifully and falsely. Reporting only when it flatters. What the indicators reveal in a resource-limited facility. So what do you see first? Broad spectrum agents used by default for surgical prophylaxis and for undifferentiated fever, very few cultures sent. I will tell you, as somebody who works in the eastern region, this is something we're all privy to. We've all we've all done at one point or another in the absence of a culture. We end up prescribing broad spectrum agents by default. So it is essential that in the absence of cultures in regions, that we use existing channels and feedbacks that are in the country, like to refer to the NMRL lab. What the indicators show: a low blood culture utilization rate, of course, because we're not culturing enough. So you're going to get false positives, or rather false negatives. A low blood culture utilization rate, a low access share, and prophylaxis routinely continuing past 24 hours. What that means, resistance is not absent, it is unmeasured. Empirical practice hardens around habit because no data ever contradicts it. What changes it? If we raise our culture volume fast, we feed the resulting local antibiogram back to the prescriber monthly, then set a prophylaxis duration target. Make it survive past the pilot. So we keep it small. 8 indicators is a lot, but they are more than enough. See what is important for your facility, what can be done by your facility. If surgical site infections, if your facility does not have a theater, then SSIs, there's no reason to measure them. So you take the indicators that you feel is important, attach it to an existing power. So QI structures, accreditations, performance contracts, existing reporting lines. Fund the denominators. Reagents in a working water supply are IPC indicators in disguise. Budget for the capacity. Sorry. Protect the focal person's time and publish and share locally. So let's see what good looks like after 12 months. So hand hygiene compliance of greater than 70%, hand rubbing consumptions of greater than 20 liters. What I'm showing you here is what the WHO expects you to have as your measurables. They expect you to have a hand hygiene compliance of greater than 70%, a hand rub consumption of greater than 20 liters per 1,000 patient days, CCI surveillance, SSI surveillance of 100%, prophylactic stopped in less than 24 hours for greater than 80 patients, blood culture utilization rising. You see, they didn't give us an explicit number because utilization depends on the availability of blood culture in different settings. So they are hoping you'll see a rise in the culture volume, where access share of greater than 70% of total antibiotic consumption, and IP cuff bands. So if you started at 0 to 200, we're hoping you move to the 200 to 400 band, and then you go to good and excellent. If you remember nothing else, just remember this: IPC is an AMR intervention that acts before the prescription. It reduces both the selection and transmission. Count activities and you will persuade nobody. Every indicator needs a denominator. Cover all 4 levels: structure, the process itself, the outcome, and the bridge indicators we talked about. Blood culture utilization decides whether your resistant data means anything at all. 8 indicators which we mentioned, and claim plausible contribution, not proof. I think I am finished with my presentation.
All right, thank you.
Are there any comments, queries?
Yeah, a lot. And thank you so much, Dr. Samar. That was very, very insightful. Yeah, we've really learned a lot. Yeah. At this point, we are opening the Q&A session. Yeah, please, if you have any question, feel free to raise your hand, or maybe even you can also put your question in the chat. Yeah, then we can be able to address. But before, yeah, as we wait for the questions, yeah, I'm very grateful, Dr. Samar, for that presentation. Yeah, very insightful. So we have a hand from Lucy. Lucy, you can go on, please. You can unmute and ask your question.
Hello, am I audible?
Sure.
I want to thank Dr. Samar for a very insightful presentation. I think it goes to show the importance of IPC and its relation to AMR. Maybe mine would be to seek some guidance on her expertise as to how resource limited settings that tend to have challenges with IPC commodities, for example, the water supply, for example, the alcohol rubs, what would she advise would be the best way to incorporate IPC into such settings? That's the first question. And the second one would be, how do you convert IPC to the healthcare workers, considering that most of the other professionals see it more of a nursing duty rather than all healthcare workers embracing it. So I think that's what I'd like clarity on. Thank you for a very insightful and wonderful presentation.
Thank you very much, Dr. Lucy Ochola. Dr. Ochola is very active in the antimicrobial stewardship space. So I'm happy that she is with us. She is someone who sits, who's given us a lot of, she's done a lot of research in AMS. So thank you for being here, Doc. As per your first question, in terms of lack of water, yes, alcohol rubs are encouraged, and you'll find that in a lot of settings here in Wajir County is water, it might not be available 50 to 60% of the time. So that's why I added alcohol hand rubs compliance. So if we have a protocol that's set out to each and every department that this compliance is what is expected, together with the hand hygiene compliance, then we measure that each and every month. Then we'll be able to at least stop MDROs from spreading. I hope I answered your first question. In terms of IPC being, it's not, you're right, it's not taken as seriously as AMR is, which is funny because if you do a good job at IPC, you will not have a lot of AMR cases. So it's an interesting thing. So I think the thing that needs to happen, and we've been vocal as their reports. And we also want to encourage that, to encourage the compliance indicators, to encourage the alcohol rubs, and to encourage all these indicators to get the measurements, to be able to see what's happening. So in what we did here was we gave them incentives, sort of like if there's any IPC training, so they would be the first ones to go. But the best incentives is money. And if what we planned here, actually, the hospital is, if a department does very well with IPC, then we would be able to choose the IPC focal person and sort of gift them. So it will create a sort of healthy competition amongst departments. And then you'll end up seeing all these indicators being brought forth to you. Sometimes we need to be a little out of the to encourage people to actually passion medals, to holding some level of awarding system to different departments, creating that level of healthy competition amongst different departments. And then you start seeing, okay, maternity is really going, their hand hygiene compliance is coming up. Perhaps the surgical team is also their site infection rates are coming down. And then that's something that encourages an institution works best. That's what I've seen here. So yes, I think that's how you would go about it. But they also need a lot of knowledge that needs to be reiterated, even if it's like monthly continuous medical education, to explain to them the importance of IPC, not only to the patient, but to the staff as well. To ensure that the MDROs don't affect our staff, because if our staff are sick, then the hospital suffers as well. So there is an importance to reiterate it to them. There's a high hepatitis B rate here. Dr. Ochala is very much aware. We work very closely together. So one thing that's very important is if we ensure that staff, and we've been seeing high number of space in other spaces as well, that is getting that's affecting staff. So we just need to have a much more broader way of encouraging IPC to be uptaken, and not separating the two, but bringing them together. I hope I answered Doc's question.
Right. Thanks so much, Dr. Samar, for that response. And I hope, Dr. Ochola, I hope that those questions were responded to adequately. So we still have a few more minutes for Q&A. Yeah. So please feel free to raise your hand, or also maybe you can put your question in the chat. So I have one question, Dr. Samar. And so this one regarding the preparedness of the primary healthcare centers, especially in the IPC, I mean in the ASAR region, where I think you have a lot of experience in. How is it, especially in attaining the WHO IPC requirements? Yeah, for example, assembling the IPC committees and very other requirements that you just mentioned. So how is the feasibility of this, especially at the moment, and probably even comparing pre and post COVID-19 pandemic? Over to you, Doc.
Yes, it's we are in the poorest part of Kenya. So having an IP, for example, the WHO IPC framework, for it to be fully utilized, there are some elements of capacity that they expect of you. So you would go to a primary healthcare facility and you will not be able to find half of the staff, perhaps, or half of the capacity. So there is a smaller framework known as WashFit. I I went through it vaguely, but what it does is it carries what is important from the WHO IPCAF framework, and it'll be able to give you very simple but very important measurable indicators to be able to say, okay, yes, we don't have a fully functional IPC committee here. Perhaps we don't have continuous medical education in a health center, but we don't have water, for example, but can we get hand hygiene compliance using the alcohol rubs? Do we have spacing? Is isolation possible? So there are some elements in which you'll be able to borrow from the IPCA, it's known as the wash fit, and use that for primary healthcare facilities. But in reality, the lower the facility specialization you go, the very difficult it becomes for you to carry out some IPC, just the core functions, the core components of it. So I think that's why if we reiterate the most important things out of IPC, then we'll be able to teach that to primary healthcare facilities. Ensure that even if you don't have water, do you have your alcohol rubs 24 hours? Do you even have a room where you're able to isolate a patient who comes to you and perhaps you're suspecting an MDR? You can't do a culture. Maybe this patient has gone to 4 centers. Now you're beginning to think this patient might be having resistance. So is there a place I'll be able to isolate this patient? Measurement, am I able to ensure empirical agents are being used? Because maybe you'll not be able to get the perfect first line that you have. Can I get other access drugs to begin with? Because we have cephalosporin doesn't mean I have to take the cephalosporins. Do I have piperacillin tazobactam on ground? Do I have trimethoprim, sulfamethoxazole? Is it available? So there are ways in which we can use the frameworks that exist towards our primary healthcare facility. But essentially, we will not be able to run the WHO IPCAF on a facility that does not have the components to be able to measure them.
Thank you. Thanks so much, Dr. Samar. That was very informative, and thank you for the response. Any other question? Still, maybe 1 or 2 more minutes in case. Yeah, I was actually expecting many questions, yeah, but I can't see any. Anyway, maybe everything was quite clear, which I believe so. Yeah, it was also clear on my end, and maybe that's why we're not having, yeah, a lot of questions as I thought. It was a very interesting discussion, very critical discussion that we need to be having more frequently, yeah, to see how we can strengthen IPC efforts, especially in the primary healthcare settings, to curb AMR. Probably we'll be carrying out more of these sessions in the coming days. Yeah, so we'll let you know, yeah, when we'll be having other sessions. And yeah, I would like to convey our sincere gratitude on behalf of my team from Zihi Institute for everyone who has joined today's session. And more importantly, to our guest speaker, Dr. Samar Abdullahi. Yeah, we're very grateful for honoring our invitation. And at this point, I would like to invite you, maybe if you can, in case you have the final remark, yeah, before we end the call.
Thank you, Zihi Institute, for the invite. While I was researching, I also learned a lot as well. I think my final remark is learn to put IPC next to AMR. As long as you know your indicators, then you're good to go. Put the two together, whether it's a small facility or a big one, learn to put IPC indicators next to AMR. If you stop one, the other will not happen. I think that's my takeaway. Thank you so much for the audience and for having me.
Perfect. Thank you. Very brilliant takeaway. We are now getting to the end of our today's webinar, and I wish everyone a good evening or afternoon, but I believe it's evening for most of the audience here, as I can see. And we hope to see you in our upcoming sessions. And thank you so much again, everyone, and bye.